Good afternoon, everybody. So I'm a PhD student from the Department of Computer Science, New Jersey Institute of Technology, and I'll be presenting my work done with Dr. James Giller, who's my PhD advisor. And our research topic is detecting, reporting, and alleviating racial biases in standardized medical terminologies and ontologies. So when we started with this research, we had basically 4 questions that we were finding answers for. So the first one was, what are the major forms of injuries or events that is faced by victims of bias incidents? And second, is there a dedicated ontology which covers the major hazards faced by people of color as a result of the unconscious bias of the society? And third, do our standard terminologies contain relevant codes to cover the racial and ethnic data? And lastly, are there necessary concepts present in the terminologies so that a healthcare worker can properly record data in the electronic health record? So moving on to the motivation of the study, it all based on the single question, what is implicit bias? So according to Brownstein in the Stanford Encyclopedia of Philosophy, implicit bias is the attitude resulting from the unconscious stereotypes and prejudices that we harbor towards certain category of people, which can be based on their race, language, gender, sexual orientation, educational level, etc. And bias incidents have been recorded in some healthcare settings, and victims of bias incidents often end up in healthcare system. So for our research, we had this main pillar of healthcare setting and what are the injuries happening within and outside of the healthcare setting. So now talking more about the bias in healthcare setting, it is often unintentionally or unconsciously triggered. As Dr. Fee Wang presented in his keynote speech, the long prevailing misconception of pain tolerance is one of the many instances in which this bias comes into picture. Other instances include denial of quality treatment, denial of referral to a specialist, denying nutritional counseling, providing substandard care, etc. And it is not just the healthcare workers that come into picture. So the personal biases, mainly unconscious bias of the software developers, gets codified into the software they develop, and this affects the workflow of the healthcare organization. So standing outside of the healthcare, we categorized 3 of the areas where the people of color are at more, not danger, are at a place where they get more injured or they face more hazards due to the bias incidents. So these are police interventions, workplace harassments, and hate crimes. So as we all know, African Americans experience more physical police intervention than a Caucasian counterpart. And also this excessive use of physical violence, it not just damages life and limb, even though it causes shocking damage, it also goes beyond physical force. It affects one mentally as well as emotionally. And the incidents that get reported in the news or shared across the media just constitute mostly on the tip of the iceberg. For example, there was this interesting study by the Texas A&M University wherein they monitored over 2 million 911 calls. And the research was pretty shocking because they found that the same police officer, when deployed to a Black neighborhood, they had almost 2 times more likely use of force when the same officer is deployed to a white neighborhood. And similar such study happened in New Jersey also. So this is a statistics that is made by New Jersey Advanced Media. So they collected use of force reports from 240 cities and towns in New Jersey. And these reports range from 2012 to 2016. And they shockingly found that, as represented by the red dots, almost 173 police departments had these places where a Black person was likely to receive more force compared to a white counterpart. For example, if we look at Patterson's, if I'm a Black person living in Patterson, and if I'm being arrested, my chance of experiencing force during the arrest is 4.9 times more likely if I'm a white person. Similarly, in Pompton Lakes, it's over 3.5. And in South Orange, it's almost 1. And other than police interventions, we looked at hate crimes and workplace harassments. And we all know the labeling of COVID-19 as Chinese virus. It caused an uptick in hate crimes especially targeting people of Asian ethnicity. And workplace harassment, it affects more of racial and ethnically underprivileged population. And African American and Latinx forms a major proportion of people doing low wage jobs. And the people of color who is performing these low wage jobs are at higher risk of job related injuries ranging from exposure to chemicals to heat strokes. And people of color, who again forms a higher portion of frontline workers, they are at a higher risk of COVID-19 exposure and cases of extreme hospitalization. And according to the latest data, a non-Hispanic Black, his life expectancy on an average is lowered by 2.7 years. So there were multiple instances when Black community members have been denied even a basic COVID-19 testing or even denied emergency room services. So when we look at all these problems, or when we have all these problems lined up, it shows there's a potential structural racism in the healthcare settings. So what can medical informatics contribute to the solution of this problem? So it is electronic health records. So electronic health records store the data in a standardized way, and in structured reporting, terms in the electronic health record are extracted from terminologies or ontologies. So when a term is missing in the underlying ontology, the data cannot be properly recorded. And if the data is not properly recorded, if the data is properly recorded, it can be used for the training of the healthcare workers, and also it adds up to the data, which already shows the bias that exists towards the people of color. So now speaking of what is an ontology. So ontology is my research topic. So ontology is the representation of knowledge in a domain. So we have this subject knowledge that we represent using concepts, or more specifically boxes. And to link between these boxes, we have these arrows. So basically we have a black arrow as shown in the diagram, that is a relationship, and we have semantic relationship color coded using red arrow. So for example, if we look at this, a malignant intestinal neoplasm is a malignant digestive system neoplasm. So it shares a relationship, and malignant intestinal neoplasm shares a semantic relationship with intestine, that is associated anatomic site. So I can read this as malignant intestinal neoplasm has an associated anatomic site, intestine. So moving on to, or drilling down more into our research, the target ontologies that we considered for the first phase of this research are SNOMED-CT, NCIT, MEDRA, ICD-10, and CPT. SNOMED-CT is a systemized nomenclature of medicine clinical terms. It is the most important clinical ontology with around 350,000 concepts. And NCIT is maintained by the National Cancer Institute. It has vocabularies for cancer-related clinic care, research, administrative activities. And MEDRA, it is a medical dictionary for regulatory activities. It covers drugs, advanced therapies, and some medical device information. And ICD-10 is the 10th edition of International Classification of Disease that is maintained by the World Health Organization, or WHO. And it is a widely used medical coding system, especially by medical insurers and billers. And current procedure terminology, or CPT, it is a medical code set for medical, surgical, and diagnostic procedure. Now, UMLS Metathesaurus. So UMLS Metathesaurus is a repository of over 200 medical vocabularies, and it is maintained by US National Library of Medicine. So for our research, we used UMLS Metathesaurus browser to extract codes, or to put it in simple words, if I want to see if fever is there in my target ontology, I would use UMLS Metathesaurus browser. And if fever is present in our target ontology, we get code for that, or more specifically concept IDs for that. And as one of our goal was to identify the ontology that is dedicated for people of color, we looked at Obo Foundry. So Obo Foundry is open biological and biomedical ontology. It is a repository of interoperable ontologies that are logically well formed and scientifically accurate. And it has over 190 ontologies as of yesterday. And Bioportal is maintained by the National Center for Biomedical Ontology at Stanford. It is a web portal that provides access to 918 biomedical ontologies. So coming on to the methodologies of our research. So as a first phase, we extracted major race and ethnicity terms, and we looked up in our target ontologies. For example, we had this term African American and Asian. So we looked at our target ontology and we found that it didn't have a code in ICD-10, CPT, and MEDRA, but it did have a concept ID in SNOMED-CT and NCIT. Similarly, we looked at Stanford Bioportal and Obo Foundry to see if there is a dedicated ontology covering the injury or events faced by people of color, and also to extract concepts or injuries during a police intervention. We looked at public databases and news reports. Similarly, to extract the concepts of denial of care. So denial of care in hospital setting is, the data is not widely available. So we had to look into the articles in ProQuest Central and Medline. And to extract the data for hate crime, we use non-profit databases. So one such example is Stop API Hate. So Stop API Hate gained so much popularity after this whole Chinese virus thing. So it is a place where people log such incidents where they have been victims of bias. And also we utilize the hate crimes listed in US Department of Justice. So once we had this whole lot of concepts or injuries in hand, we had to refine it. So the rule of thumb, or basically we used 3 rules to refine those. The first one was to filter it based on the frequency. For example, when we look at the data of police intervention from 2016 to 2020, the police use of chokehold was very high. So we finalized that we need to take the concept chokehold as our one of the concept. And then we look if the concept that we have in hand, it can be covered by a synonym. For example, if we have asphyxiation due to spit hood, we looked at its synonyms for asphyxiation like strangulation or suffocation, or for spit hood, we looked at spit mesh, mesh sac, etc. And also the third rule is we tried to get the concepts coded from post-coordination SNOMED-CT. For example, if we take injury of head in police custody, I do have a code for injury of head in SNOMED-CT, and I do have code for under legal intervention. So I can still code it using SNOMED-CT. So coming on to the result, we were unable to locate an ontology that is dedicated to the hazards faced by minority population. Hence we developed one. So that is home. It is health ontology for minority equity. And this is to be presented at KEOD conference in October. And also we did identify gaps in racial and ethnic data. So in an electronic health record, they won't be, if they are using the target ontologies that we researched on, they won't be able to quote such data. And also we identified 25 concepts that is specifically related to hazards faced by people of color. And this paper is under review at BIM 2021. So my next slide shows the table 1 of the 25 concepts. So basically in here, we have divided the category into 4. So law enforcement, occupational hazards, hazards by hate crime, and healthcare institution. So for example, if I look at asphyxiation due to spit hood, so it did have a concept ID in ICD-10, but it didn't have a concept ID in SNOMED-CT and rest of the target ontologies. Similarly, if I look at hate crime murder, it didn't have a code in any of the target ontology, and it's the same with rest. So if we were able to identify a code, we have it here, and if it is missing, we have completed it as no. So with the results, we found that 56% of the concepts existed in at least one of the terminologies, and rest 44% we had divided into 3. So 24% of those we were able to utilize post-coordination, even though post-coordination is a heavy-duty tool in SNOMED-CT and it is being implemented in ICD-11. And also 16% had concept missing. So 16% concept missing, it literally means that we were unable to, like healthcare workers won't be able to code those concepts in their electronic health records. And 4% was child missing, which basically means for example, if I take the example of sexual assault under police custody of a minor. So I do have sexual assault under police custody of an adult, but I don't have it for a minor. So those scenarios comes under child concept missing. Now coming to the conclusion. So we with this first phase of research, we concluded that there do exist gaps, or basically when a healthcare worker try to record the data in electronic health record, they don't have sufficient terms to record all these events. And in this phase, we have documented 25 relevant concepts, out of which only 9 existed in MEDRA, 6 existed in SNOMED CT, 3 in ICD-10, 1 in NCIT, and none in CPT. And as a future work, we plan to add more depth to our ontology, addressing more situations of injury. And as a first phase, we had only considered 3 of the categories: police intervention, workplace harassment, hate crime, and denial of care in hospital settings. So we plan to add more depth to this ontology. And also during the first phase, we didn't have any clinicians with us. So we hope to interview clinicians to find more missing terms of these minority affecting situations. And research in this area is really important, and we encourage other researchers to join us. So my slide follows up with the references, and thanks a lot for your attention.